All right, how's everybody doing? All right, we're on the home stretch. Isn't that great? Yes? Okay, we're gonna get energized here in a minute. So, fun little fact, we were talking last night, I wore white pants to dinner and I said, how many of you, your mom said, don't wear white after Labor Day? Well, I'm rocking it, but I do have some advice though. Don't wear white pants to a bar on Broadway Street in Nashville. They have several colors on them today that I can't really identify. I will tell you that this is the one time in my experience last night at the bar on Broadway that my partner probably doesn't want me to say their name, Quad Med, who I was out with last night. There were things that happened. There was a strange guy who was following us. There was a fall. I think there were a couple marriage proposals. They were singing with the band. There was dancing. It was fun. So anyway, Nashville has been great. All right, so let's get started here. So I'm going to talk about some of the ways that we look at benchmarking and evaluating our centers. Just a couple of quick slides about who we are, Huntington Ingalls Industries. We have 44,000 employees. We are the largest supplier of ships to the Navy and to the Coast Guard, and the exclusive supplier of aircraft, nuclear-powered aircraft carrier for the Navy as well. So lots of other stuff there, but we have two locations, Mississippi and Virginia, which is where I'm located. We have two on-site centers, as I talked about. The why is the same as all of you guys, right? Why we're doing this. We're open 6 days a week, 7 to 6 Monday through Friday, and then on Saturday, 8 to 12. It's an appointment-based system. It's not a walk-in urgent care, even though lots of people sometimes think it is. We're pretty extensive. We have on-site lab, x-ray, pharmacy, and physical therapy, dental, and vision as well. And our employees and their dependents, as well as retirees, can use it. You see on the right-hand side, just a clarifying point that we have 94% utilization. That's not utilization of our employees. It's actually we have 94% capacity. We're at 94% capacity. In other words, when you look at our schedule, about 94% of it is filled up. So our model is not unlike yours. I'm sure we really are focusing on that whole person care. As you can see, that we have the patient in the center. Again, our services are down there, and I'm kind of running through these slides a little bit because I want to get to the big bang for the buck here. But really, that idea that primary care is driving the services that we're providing is key, right? That's what we're focusing on, and really being the hub for all the different spokes that we're trying to engage our employees in and their families. Obviously, we're trying to look at this continuum health spectrum and the continuum, and always trying to get people back to that wellness state. No matter where they are on the spectrum, we always want to operate from a point of wellness and getting them back to their best well state. And if not, or if they are there, then to maintain that as well. Not rocket science so far, right? You with me? All right, just making sure. We're on the home stretch. Remember I said that. Okay, so here's the fun stuff. So benchmarking and ROI versus VOI. So I'll tell you a couple things about ROI. At our company, while we probably have one person, the CFO, who really likes to talk the money, for the most part, we really don't look at ROI very often. And the reason for that is it's hard to measure, right? It's hard to consider when you think of the components here under ROI. It's hard to consider some of those soft savings, such as productivity and absenteeism, presenteeism. How do you measure that? If somebody, I'm sure somebody does. We can apply some good, better, best practices to that. For example, what did the book of business say about how much time you spend away from work and how much lost productivity there is there? So you can factor those things in. We can also look at some aggregated claims data, but really getting to the state of looking at full claims to file and doing a comparison to that, and your services really gets you the best ROI calculation. But for us, it's not really something that we hang our hat on too often, but we do have a money slide. So here it is. So here's our money slide. So like all of you, your healthcare trend was rising, right? Take a moment to look at this and just point out that, as you can see, here's where the trend was going. I don't know if my pointer is working. Apparently this was at the bar with me last night. Nope, doesn't work. Okay, but you can see where the dollars and cents are. The healthcare trend was rising for us, and we knew back in 2013 that we needed to do something different. Now, I'd love to stand here and say that our cost savings have been all related to our on-site work, but in fact, it has not been. We invested about $100 million in programs over a course of time and netted what we think is about $725 million in company cost avoidance. And there are some real actual savings in there as well. So what I really want to point out too, that as you can see in the light blue and blue boxes are our own numbers and how we changed our trend. But really what I also want you to know is that in the dark blue line, we didn't change our trend by shifting our costs to our employees. And that's really important. We didn't have them pay more so that we were paying less. So that's an important component. So that's our money slide. And this is really, if we were going to look at ROI, this is where we garner some of that data to really come to an ROI number. But we also look at value on investment. And if I were going to say one thing about value on investment, you have to look at that first. The ROI comes over time, right? However you want to calculate it for your center or for your work, it comes over time. It doesn't come immediately. The VOI, you have to be patient and working through what the VOI is. And we ferret that out in some of our performance guarantees. And this is what we work with QuadMed on. I will say when we first started, we were in that infancy stage. And so what was important to us, service quality, right? So wait times and provider capacity, satisfaction scores. After a couple of years of those being very high, as we would hope and expect they would be, all those satisfaction scores, we thought we need to do something a little bit more robust. We weren't going to just hang our hat on the fact that people were happy with the service because we knew QuadMed would provide that great service, but we really wanted to dive in deeper and have some performance metrics around financials, wellness, and utilization. And I say clinical for last because that's the one really, as a nurse, I'm most excited about, that we are able to now validate that our diabetics, our hypertensive patients, our asthma patients are getting better, and our people with mental health issues are getting better as well. So really taking that next step beyond just satisfaction really is key for, I think, value on investment. So some of the things that we're going to measure and compare really have evolved over time as well, because we didn't have a lot of data at first, right? But we wanted to be in a position to show that over time, again, our employees and their families were getting better. So I'm going to give you some examples of things that we measure. First, what our employees think. Oh, I'm not sure I'm going to need that anymore. Did you pick this up at the bar last night? Because I think I dropped it. No, I'm just kidding. Yes, that does work. Okay, I'm not sure I'm going to need it anymore. I think I only need it for that one slide, but I'm going to hold on to it. But we're going to talk about, I'm going to give you a couple of examples of what our employees think, because that's value on investment, right? We want them to feel like their health is getting better. We're going to talk a little bit about our biometric data. We're going to also I'm going to give you an example of comparing our PCP patients with our non-PCP patients, and then health center users versus non-health center users, and then compared to some national benchmarks. So this is some of the things that you should be looking for value on investment. So I'm going to give you some examples of each one of those. See, you got me all discombobulated. Now I have to pick up this. All right, here we go. All right, so from the employees' perspective and their family members, we have a program called Know Your Numbers, probably not unlike some program that you have where you are gathering biometric data. We have this only for our employees, but I put this up here. You can see all the facts on the left-hand side, but on the right-hand side, we have numerous stories. So many employees saying, I didn't know what A1C was. I didn't know that I had a problem with it. I didn't know that my hypertension was out of control, whatever it is. We have so many anecdotes from patients that have said, this was my first entry into the healthcare system. This was the first time that I've used anything because you alerted me to something. Yay. We're almost done too. All right. So really, the employee's perspective is really our greatest value on investment, right? And then looking at using that data in a cohort, and I'm not going to spend a lot of time on the data as much as to give you some examples of how you might look at using this data. So here we're talking about blood pressure, looking at a cohort of patients between our in our Know Your Numbers program who were PCP patients and non-PCP patients at our family health centers. And we can see that those that had a PCP at the family health center had more positive outcomes in all categories for blood pressure with the Know Your Numbers program. So again, being able to look at the effectiveness of your programs, knowing that ultimately what we want out of this relationship with our provider is that our employees are getting better, right? Here's another example of that same cohort looking at A1C and cholesterol. Again, showing improvements for the people that had Quad Med as their PCP and those that did not. Just seeing improvements across the board for all of those. So the first thing we looked at was our employees and their perspective of their health getting better. And now we're looking at the Know Your Numbers program and comparative data over a 3-year period. And then let's look at our actual PCP patients. And when we talk about blood pressure, again, we know all of the problems associated with that. But in this 2-year cohort, and you can see the numbers down at the bottom, so a very large cohort here, looking at our PCP versus non-PCP patients, and we saw more positive outcomes in all categories for blood pressure for all of the patients that went to the Family Health Center, not just those that did the Know Your Numbers program, but all patients who went to the Family Health Center. Same thing with A1C. Again, not getting into the data too much, except the point of an example of improvements over time. In this one, if you're not measuring some improvements in mental health for whatever tools you're using, I highly encourage you to do that. We all know it's an issue. It's sometimes the one that's left off, right? It's easy to measure somebody's blood pressure. It's easy to understand an A1C, but to use the various tools that are out there to really look at somebody's mental health over time. And I'm so proud of us for being able to have a cohort related to this as well. Just a note about this slide. So what we're trying to show is that we had a group of people who have moved from that severe depression back to the remission stage. So again, showing a really important improvement in this 2-year cohort as well. So we looked at our employees' perspective. We looked at the Know Your Numbers cohort group. We looked at the larger group of anybody who came to the Family Health Center. And now we want to look at people who use the Family Health Center and people that don't. And this is actually one of my favorite slides, because what does everybody talk about? Here, Larry, I'm going to get out I'm going to use this. Everybody's worried about this, right? And so it's really great to be able to show that those that have used the Family Health Center, in fact, they have fewer ER visits. Interestingly enough, they also have a higher risk score. So they're sicker, presumably, but they use the ER less and they have fewer admissions as well. So again, a testament to great care at the Family Health Centers. And then the last thing is to look at yourself and benchmark against national norms. So when we look at screenings as one example, you can see that that Quad Med outperforms the nation in all 3 cancer screening categories. Again, those that go to the Family Health Center have better screening rates than those that don't. So you can kind of see that was 5 different categories of how you can look at data and how you can compare the performance of your on-site clinics or centers rather, to various different levels. I'll give you also an example, and we have our Take Control program, and I'm hoping that we get a spot on the January agenda for Quad Med to talk about this, because it's such a great program. But our Take Control program for diabetes, we have over 500 people enrolled in it who are active members enrolled in it right now. And 82% of those members have an A1C less than 8%. You can see 84% have their blood pressure controlled. And then 21 is the average asthma control test score. So again, looking at different ways to look at program effectiveness. So how do we engage our people? Just you guys might have seen this slide from me before, but I always like to pull it up here, because no matter what we do, relentless messaging is the key, right? You can tell somebody 5 different times, and until they really need that service, they might not really realize what you said until the 5th time. So relentless messaging, focusing on the right population. Patient testimonials are very, very important to us. No matter how much I get up and say how great the Family Health Centers are, until they hear it from their coworker, it's not as important. We use mailers to home because we are an 85% male population, and who are the decision makers? I know nobody really wants to say it, but it's the woman at home, right? And then we also, for all of our communication that we send out, there's a call to action. It's not just that we're feeding them information, we have a call to action. Make an appointment, call now, whatever it is. These are just some examples of some of the campaigns that we have. Manpower is one of our newest ones. And again, since we're 85% male population, again, the effectiveness of these communications, we also track as well. We support positive outcomes, obviously, in the work that we're doing. A couple other notes, our workman's compensation claims are lower, and our people who use Family Health Center have fewer missed days at work. And there's a couple other things on there. I see Larry looking at his watch. I'm breezing through here. What are some of our keys to success? Certainly, again, that VOI, that value on investment, the patient experience. Making sure that you're offering as many services as you can, making sure you have the right partnership. If your partnership is not looking at some of the things that we put up here, you need to go back and say, hey, it's not enough for you to tell me that they're effective, show me. So QuadMed has been an excellent partner in that respect. Marketing, having some dedicated resources, and then measuring, and adjusting your services based on how things are going. Just one last example of a patient experience. Again, it all boils down to this for us. The real value of investment is that people's lives are changed and their health is improved. Phew, okay. That was a lot. And I didn't spill anything on my white pants, so. All right. Thank you.
That kind of introduction and stories about Broadway, combined with those data in 20 minutes or less, there's nobody going to beat that. That was impressive. Get my stuff situated here. We'll be there shortly. Am I going the wrong way? Yeah, I'm going the wrong way. Quick start. Okay, good. There we go. Very good. Well, extremely well done. Congratulations to both you and QuadMed. That takes an awful lot of work over a long period of time. HII through QuadMed is accredited under HHC. HHC, the Accreditation Association for Ambulatory Healthcare, a number of employee-based vendors and organizations are. What I'm going to do is talk a little bit about HHC, what they are, what they do, what their standards are, particularly the quality standard, and then comment about what you saw in the last presentation and what HHC teaches their organizations to do and what they evaluate. So I'm going to put these aside here so I can open this up. Good. Here. The slide deck that I'm using is actually one used by HHC to train organizations and entities that are going to be undergoing accreditation. Not sure how much of that we'll get into. It focuses on quality improvement. Quality improvement is something that they used repeatedly over time. And I didn't check, but that's a pretty good guess. And it's a cornerstone for the quality improvement program. If we do not talk about those, just please read them because there's enough narrative there that you get a sense of what it's all about. Oh, I'm Dennis Schultz. I'm a practicing physician with the Ascension Medical Group. So I've got patients waiting for me on Monday. I've been involved with HHC for 25 years or so and served in a wide variety of capacities. I've also been involved with employee-based clinics, probably for about 20 years in primary care, and I don't even care to tell you how many for occupational, much longer than that. More than that, I had the privilege of being a patient in a system very similar to HII with that kind of data and a provider in that same system. And I'll tell you for both patient and provider, phenomenal experience. From a provider standpoint, to be able to focus on the care of individuals, not worry about chasing billing, and to know that there's a system backing up your patients. So you've got these different things that you can use, you can coordinate. It was a very, very gratifying experience. So For the next one. A little bit about HHC. So they've been around for more than 40 years. They focus exclusively on ambulatory facilities. So there isn't any hospitalizations or nursing homes or things like that that they do. As an accreditation organization, they do three things. Number one, they create standards. And I've got the book that they've got right here. They create standards and they update those standards. So there are expert panels that are going over these routinely. There's a standards committee that accepts the recommendations and makes modifications. And they have a process of public comment on their standards. And that's done every time they come out. And they really encourage all of their accredited organizations to comment about how they feel those standards are, what needs improvements, what doesn't, and they respond to that. Number two, they train and deploy surveyors. So for HHC, if you become accredited, you're going to get a survey. Somebody's going to come and visit. I'll explain that a little bit. It may not be immediately, there may be a delay, but you're going to get a visit to verify that what you say you do, you're actually doing. And the surveyors that pick to do that are going to be tailored towards your organization. So I do primary care, I do occupational health. I do not like to go into surgical centers. That's just not what I do. We just went ahead and brought aboard a number of additional new surveyors. I forget the ratio of applicants to surveyors picked, but it was extremely high. And I got to interview several of them. They were excellent. They were impressive, both in terms of their experience in the setting, as well as the positions, quality management, as well as practitioners, as well as practicing administrators. So they do a very, very nice job there. And then they support clinics. There's been a big push to support clinics and entities getting accredited. In the past, there were always presentations that you could go and learn about what accreditation is and how to become accredited. What they've done now is expanded that to provide a lot of support. They call it their 1095 initiative. And that's because there's 1,095 days in the 3-year cycle from one accreditation to the other. And they're trying to encourage organizations to maintain that momentum that they get when they come up for survey for the next time around. They accredit 6,600 different facilities, which range from prisons to Coast Guard to employer-based clinics to surgical centers. And you got to ask yourself, how the heck do you do that? How can you create standards that apply to all those kinds of situations? And the answer largely is that they have structured their standards in a way that's adaptable. So the standards are about 25 different chapters, each cover a different area. And then you generally pick and choose. Well, the first 8 chapters apply to any organization that undergoes accreditation. And they address things like quality of care, patient rights, administrative and governance, management of medical information, those kinds of things. Then the rest only apply if you provide a service. So if you are doing lumps and bumps in a primary care clinic, then surgery and anesthesia apply. If you are doing if you have a X-ray unit, well, then imaging applies. If you have lab. But it means you can pick and choose among different organizations that provide different levels of services in different kinds of environments. And secondly is the wording of their standards. So the standards, some standards are rather specific, like the ones that have to do with vaccine. Vaccine management is vaccine management. Others, many others are not. They're general. They tell you, the organization, what they need to do, but they don't tell you the specifics. And those come out very clearly in the quality standard that we will mention next. So here are the organizations that are currently accredited that you'll see out front under HHC. That doesn't mean, having your name up there doesn't mean that every single facility that you manage is accredited. It varies. And it doesn't mean that every single facility that is listed as accredited by those organizations has had an on-site survey. It varies too. Eventually they all will, but it's because there are different products for different types of organizations, one that only operates 1 or 2 clinics, others that operate a whole plethora of them. However, it means that every one of these organizations understands the principles behind the standards, including the quality standard. And that quality standard says things like, you have to have a comprehensive program that addresses all the important areas for your organization. You have to identify data that's collected to be able to monitor these programs, and you've got to use that data by trending it, tracking it, I'm a Badger, so I hate hearing that from Michigan State, but that's me. Anyway, Yeah, that's a Michigan State group over next door. Where was I? A quality standard, I guess. So you have to identify the data that you're going to be tracking, trending, and benchmarking internally and if available externally, and then how you use that data. And that data is commonly used to generate quality improvement studies when you see that it's not exactly where you want it or you think there's an opportunity. The standard also says that you have to disseminate that information throughout the group, you have to use it, and of course it says that you have to have a team identified that manages the whole process. So those are the general terms. If you are a medical home, high-level primary care as HII is, then there's another requirement, and that is that you do a quality improvement initiative that shows sustained improvement in each of the major areas that are identified in that standard, and that includes relationship, access, comprehensiveness, continuity, and clinical care. So the slides you just saw before these slides were very, very impressive. What they didn't include was the journey, how to get there. It hinted at it, clearly hinted at it, but you know that when you open that door and let your patients in, and when you turn on Epic or whatever EMR, and you start the data feeds from the different health insurance plans that you've got, you don't generate numbers like that. It takes a lot of work over a long period of time, and it's actually built on a series of steps that go up, sometimes down, sometimes back, and then back up again, right? So initially, it's a matter of making sure that usually with most organizations, it's a matter of making sure your data is accurate, that you're getting at the groups that you want. Secondly, the second thing that it usually means is you've got to build up the practice with enough PCP patients so you can generate that kind of data. You know, you need a minimum number to start reporting significant data for A1C, hypertension, and all the rest of that. Then once you get there, you start moving along. You take a look at those initial slides, they don't tell you what the quality plan is, but they tell you that they're following one. The performance guarantees, for example, identified the important areas of the organization and it listed out those metrics for each one of them. It's a performance guarantee, so you know that's being tracked, trended, and improved upon year over year, quarter after quarter. Right? That's the way it works. If you take a look at the slide that talked about the continuum of care with catastrophic cases going on, those are tracked. So much of this is tracked and trended and improved. And that is a cornerstone of what HHC has in their quality improvement standards. When you saw the different programs that were put in, like the men program, I suspect that was because folks were concerned they weren't capturing enough. They had data to say, you know, we're doing pretty good, but not this group. Let's initiate a program, see how it works, and move from there and build upon that. And that's part of what HHC, a big part of what HHC trains. Are we time-wise? What? We're close? Okay, you tell me when to stop. We'll just go through a couple of slides. And this is just to demonstrate what they talk about. When you're let's get to that. So it talks about, this slide is there because a variety of organizations use different kinds of quality improvement initiatives or different kinds of templates. This one, which is the plan, do, check, or study and act, is one I know the Coast Guard likes to use and several other entities like to use. The point is here, it doesn't make any difference what type you choose. What's important is that it addresses all the different areas that are critical for making a quality improvement plan work. It mentions team, but we mentioned team initially. Usually it depends on the size of the organization, but there's usually an oversight quality combined with individual teams that work on different issues. Small organizations, everybody does everything, basically. Here's the biggie though. This is what it's all about. A purpose statement that tells you why you're doing it, what you're doing it. It covers a number of different elements and the goal. If you get those two correct, a measurable goal and a purpose statement up front, the rest of it falls into place a lot easier. And so there's a great deal of emphasis on trying to identify those elements. The problem statement, number of slides that talk about that. I'll have you go ahead and read those. And I like this one because honestly, if you don't get the problem statement and the goal correct up front, if there's confusion there, that confusion magnifies across the board. And you realize that you're going to have to stop, regroup, and do something different. What is a good problem statement? It tells you right there who, what, where, when, how prevalent, and then turning that into a number. It's always keep in the back of your mind SMART goals when you're doing a quality study. SMART goals, they're specific, measurable, achievable, relevant, and time dependent. If you can get a goal that's that, again, you figured out how to measure, you know what you're looking for, it makes the whole process less easier. This is an example that they give using pizzas, but here's the one we want to look at. It looks at a clinical setting, and it's an excellent statement. Our physician staff at the Main Street location and primary care perform hand hygiene as required before entering and exit a patient area. 66% of the time, performing hand hygiene greater than 90% will reduce infections, okay? That gives you all the information you need. It's specific enough, you know how to focus your intervention, and they're getting to what the goal is as well. So clinical nurse practitioners and others, they're doing pretty good. The docs, not so good. We need to focus on them. Across the board, well, there are some issues there, but this one is the big one that we really need to focus on. And we've done some preliminary measurements, so we know how to go about getting this information. It's 66%, we want 90%. Then it goes on and gives you examples. If you jump to the conclusion and come up with a solution before you've done the analysis, it may or may not work, and it eliminates consideration of things that may be much more important than the TV, for example. Locking them up may be a value, but what is the issue? How do you know if you're being successful? You don't know with that statement on the left. And a general statement without giving specifics or measurable, you don't know if you're going to, you don't know what you're going to measure to figure out if it's going to improve afterwards. So the problem statement really sets the tone for everything else. And a problem statement that links up to a number is even more valuable. And you see 90% in this case. The goal statement then is stated down below to 90%. 90%, we really want 100%. But a lot of times you have to be realistic. And I'm sure many times in the evolution of HII's data, they said, this is what we want, but this is what we think we can do on this intervention. So we're going to do this, then we're going to regroup and tackle the issue again and see where we are. Benchmarking. Now, one thing I have learned is that a lot of folks respond to benchmarking. Generally speaking, providers quite a bit. Providers are used to numbers, and if you can tell them, here's where your performance is compared to the other folks in the practice, compared to national norms, that's usually very propelling. And as long as you've done your work ahead of time to make sure that the data that you're reporting on is felt to be accurately reflects what's going on, it's a great way to get us to do things that are valuable. And this talks about internal and external benchmarking. An example of internal benchmarking, just so organizations know what that is, because with small organizations, they may not have gone through this before. They may not know about the quality process and how to measure and remeasure accurately. But from this, you can get a pretty good idea of nurse B seems to have all the right answers. Some of the other ones have partial answers. Some really are not getting it. And then there's a matter of discussion of, well, why is one working? Why is the other not working? How can we learn from what we're doing internally and go from there? Then there's also external benchmarking. If you've got data, and HHC runs a number of projects where they will gather data from organizations, and you can participate for free if you are an accredited entity. And then you'll get a measurement of where you stand in relationship to other organizations. You just have to be able to submit data to them. With that as background, you can build a pretty nice house. And HII has done that. Oh, Mona's not here, but Jen is, if there's questions about HHC.
Let's thank our speakers. Thank you very much. So, question, can you comment on measurement and accreditation for virtual care?
We are. I just didn't know if you had some thoughts about it too. But so we are just kind of in the foray of developing true virtual patient care. But we've had lots of virtual visits,
Thank you.
whether it's video or calls. As far as measuring that, they fall into the same categories of the other measures that we use. So really keeping that group of people in those same buckets has been very important, including, excuse me, including the opportunity to rate satisfaction with those modes as well.
Absolutely. I mean, outcomes are outcomes, patients are patients, and you're providing services in different format, but you should be able to apply a lot of the measurements that you have. There might be some additional ones. I mean, there's some qualifiers about, you might be asking specific questions to your folks before you start doing a virtual visit, and you can audit for those in addition to, like, are you in a safe place? Is this a reasonable, those kinds of things. So, but the basic quality parameters are going to work just fine. And I'm sure you'll come up with a number that are just fine from accreditation standpoint as well.
And I did want to mention, NAWHC is a strong proponent of the VOI approach. And again, just to kind of summarize what that means is that we identify at least 9 different areas that we think employers and their vendor partners should be measuring. And that includes access to the center and the registration process, how that works, engagement in the disease management programs and the wellness and the coaching, the medical and pharmacy costs and savings, satisfaction with the registration, with the providers, with the services, et cetera, outcomes, clinical outcomes, preventive care outcomes, productivity, absenteeism, recruitment and retention, participation in biometric programs and screening programs and flu shots, and the provider satisfaction as well. So all of those, there should be, you have to decide what your objectives are. Many times an employer will set an objective, but not set a measurement for that. And that's really key. So one question, Amy, what are the ways you measure satisfaction? And do you measure satisfaction at the end of the visit, when they're home? And what are the things you look for satisfaction?
So they get a survey after the visit, and it's an email or yes, it's an email. I'm getting a text reminder as well. So a couple things that we look at from the satisfaction perspective is wait time. I mean, overall satisfaction, but wait time, but then also how long it took to get an appointment as well. Yes. I'm looking to Quad Med. Yes. So when we look at overall satisfaction, though, we really have, it's been great to have that not be the focus of our work, right? Because the services have been, so stellar that that's not an area where we had to focus any effort really.
And what does your C-suite want to see?
It depends on which part of the C-suite. The CFO C-suite does want to see those numbers. As far as our overall philosophy really is this changing lives? Do we have data to show that people's lives are improving through on their health journey? And ultimately those were just some examples of how we can show that, but we have very robust data to be able to show the C-suite that they're getting their money's worth, even though we don't necessarily look at ROI.
Great. Any final questions?
Comment?
Oh, please, go ahead.
The work you were talking about in those areas?
Sure.
Great to blow right into a quality program. I mean, you've already done a lot of the background work for what are the areas, just pick and choose.
Great. Well, let's thank Dennis and Amy for a fine presentation.